There was another, more important part of their presentation that also confused me. As I quoted earlier, it was repeatedly stated throughout this study that endogenous testosterone produced by women's ovaries increased their risk of breast cancer. Since this study had nothing at all to do with endogenous testosterone, they were using the findings of other studies to support their conclusions. However, the following statement from the same research group appeared in the April 2005 issue of the Journal of the National Cancer Institute. Quote, postmenopausal hormone users had higher estrogens and testosterone and lower free testosterone concentrations than non-postmenopausal hormone users. We learned two things here. This group uses the word testosterone to mean total testosterone, almost all of which is inactive. And while the total testosterone was higher in that study, the free testosterone levels, the biologically active testosterone, were lower. From their use of the words, it would appear that this more current study also used the word testosterone to mean the mostly inactive total testosterone. If the active free testosterone is low, when the inactive total testosterone is high, why do they blame testosterone for stimulating breast cancer? Aren't they actually supporting my contention that low testosterone activity promotes breast cancer? By far the most important issue with this study, which I believe casts major doubt on the validity of the conclusions, is, were the findings based on an unbiased, unskewed, average population of women? You need to know that EstroTest, which became available in the United States in 1964, is a pill containing estrogen and a form of testosterone, and that the only official FDA-approved indication for EstroTest is, quote, moderate to severe flushing associated with the menopause in those patients not improved by estrogens alone, close quote. So keep in mind that the deficiency of testosterone is an established cause of menopausal flushing, and that the only officially approved reason to prescribe the testosterone in EstroTest is the prior failure of female hormones alone to control the flushing. Now back to the study. According to their 1998 statistics, EstroTest accounted for over 90% of the testosterone used by the women, and as would be expected, almost 98% of them had previously used other hormone replacement therapy. Other hormone replacement therapy, of course, had to have been the cancer-promoting female hormones. In 1998, very few of these nurses would have been prescribed EstroTest off-label, meaning that they had to have had severe flushing that wasn't helped by female hormones in order to get the prescriptions from their doctors. These specific nurses, then, were anything but typical. Their need for testosterone, the very fact that testosterone was prescribed for them, identifies them as a group of women with the most severe testosterone depletion, which led to more severe menopausal symptoms that were inadequately responsive to female hormones alone. Again, the study actually gives more support to my contention that it is the testosterone deficiency in the presence of estrogen and progesterone that is a primary cause of breast cancer. It is far more logical that the testosterone-treated cancer victims got their cancer because of their prior female hormone replacement in the face of the severity of their testosterone deficiency, rather than from simply giving them some pills containing testosterone. I wasn't able to find data in this study on the time interval between the women starting EstroTest and having breast cancer diagnosed. But as was stated in the study, quote, in contrast to observing the beneficial effects of testosterone replacement, the development of breast cancer can take years. Actually, it can take many, many years. So it is very likely that a substantial number of these severely testosterone depleted women already had early breast cancer from their female hormone replacement before they were even started on Estratest. My interpretation of this study has substantial research support. Not only did the previously mentioned University of California study fail to find a connection between higher testosterone levels and breast cancer, but the National Institute of Health stated quite the opposite in a study published in the September 2004 issue of Menopause. Quote, "These observations suggest that the addition of testosterone to conventional hormone therapy for postmenopausal women does not increase and may indeed reduce the hormone therapy-associated breast cancer risk." Is there any other reason to believe that increased levels of testosterone do not cause breast cancer? There is a group of women who consistently have abnormally high testosterone levels. These are women with the polycystic ovary syndrome, also known as the Stein-Leventhal syndrome. There have been several studies looking at the rate of breast cancer in these women with excessive testosterone. Most have found no difference in their risk of getting breast cancer, while one study showed a reduced risk. And finally, I am also unaware of any increase in breast cancer among female athletes and bodybuilders who take very high doses of testosterone for years, if not decades. This study sought to answer the question of whether postmenopausal women taking testosterone were at greater risk of getting breast cancer. They found the answer to be yes. But it doesn't seem that they looked at the question of whether it was the taking of the testosterone that caused the increased cancer or the reason for the taking of testosterone. All the evidence and all the logic and all the common sense point to the latter being the case. The tragedy of breast cancer in women is going to continue because after over a half-century of testosterone being available by prescription, there are apparently no definitive studies being done on the role of testosterone deficiency in that and other diseases. Our own National Institute of Health, with laboratory and clinical evidence, has repeatedly demonstrated the likelihood that low testosterone levels, which ultimately occur in all women, predisposes to getting breast cancer. This highly probable, deadly association between testosterone deficiency and breast cancer is being ignored. Not only do studies on testosterone's effect on breast cancer have to be initiated, but in my opinion, the case for testosterone deficiency causing the horror of breast cancer is so compelling in the face of over a half a century of no significant testosterone side effects that the burden of proof should be on why not to take testosterone. The next two videos will be about type 2 diabetes. If you're a woman, or if you care about women, help me spread the word about the existence of this disease of testosterone deficiency. Nothing is going to change in our lifetimes unless the public brings pressure to bear on the medical establishment. I'm Dr. E. Barry Gordon. Thank you for watching.